Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Ocular emergencies have the potential to cause permanent vision loss if they're not promptly recognized and treated. Ocular emergencies include retinal detachments, mechanical globe injuries, and chemical injuries. What are the signs and symptoms associated with each condition? Then there are non-emergency eye issues that are serious yet treatable, like cataracts, glaucoma, macular degeneration, and other eye diseases. During this next hour, we have experts answering questions about ophthalmology. We'll talk about corrective measures, risk factors, and treatments. As you know, this is a live program, so stay with us and think of some questions of your own that you want to ask this evening. Call us at 881-0013. You can also ask your question online as we're streaming live on Facebook. This evening's program is underwritten by Southwest Eye Institute. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing medical students to man our phones, and the El Paso County Medical Society for bringing this program to you. Good evening. I'm Flo Toll in for Catherine Berg, and you're watching The El Paso Physician. Good evening. I'd like to introduce our doctors for the evening. We have with us Dr. Javier De La Torre, who is an ophthalmologist, and we also have Dr. Ahmed Solomon, also an ophthalmologist, and they are both with the Southwest Eye Institute, and they are here to answer our questions. So we're going to hop right in and get to it. Don't forget to give us a call if you have questions, or you can also ask on Facebook. We have students to answer those. So let's start. Excuse me, Dr. Solomon. What is a comprehensive eye exam? What does that entail, and what is the recommended age for that?
A comprehensive eye exam is basically a full evaluation of your eye health. We evaluate the eye from front to back. That visit entails using some eye drops to dilate the pupil so we can physically view the back of the eye, evaluate the health of the retina and the optic nerve. The guidelines as per the American Academy of Ophthalmology is anybody who is 40 years of age or older should get a full comprehensive eye exam every 1 to 2 years. And then starting at 60 years and above annually, we should be doing that. And any patient with diabetes or anybody with glaucoma, macular degeneration, or a particular eye condition might be seen sooner.
Okay.
And I want to add that comprehensive eye exam can be done by an optometrist as well. We are ophthalmologists, but as long as the patients go to a facility that they dilate the eyes and they look in the back of the eye, that comprehensive eye exam can be done by an optometrist as well.
Okay, and they take all of those pictures?
Exactly.
Okay. Let's talk a little bit about eye emergencies. What constitutes an eye emergency?
Well, we like to say that an eye emergency is any condition that it could be a disease or it could be an injury that compromises the vision of the eye. It could be blurry vision, it could be loss of vision, and if it's acute in onset, it can be with pain or without pain. Any loss of vision, we consider that an emergency.
Okay. Talk a little bit more about those. What are common things that are eye emergencies?
First thing, the most serious eye emergency, it's when the eye structurally is compromised, and we call that a ruptured globe. And usually a ruptured globe happens because of trauma. And so ruptured globes are absolutely the most important eye emergency for us. But also there's other emergencies like acute glaucoma, where there's very high pressure in the eye, and that usually happens very suddenly. Patients have a very symptomatic, for example, they get nauseous, they have pain around the eye, the eyes see very blurry, and those we consider an eye emergency, and they don't involve trauma. Retinal detachment is another condition where we consider as an emergency, and typically the patients have symptoms such as floaters, flashes, and they can see a black shadow coming towards their vision, and that is something that we absolutely want to see those patients within 24, 48 hours. All these eye emergencies, we consider that patients should come in for a comprehensive eye exam within 24, 48 hours of the onset of those symptoms, because otherwise the vision can be permanently affected. Chemical injuries, anything that splashes the eye. This could be at home, which is actually the most common of these chemical injuries happening, or at work. We want to see those patients. And also strokes that can happen when there is lack of blood supply to the eye can cause a stroke to the optic nerve or to the retina, and those also we consider emergency. And lastly, contact lenses, which get a lot of people in trouble. And the contact lenses...
They get stuck.
Contact lenses we consider an emergency. Okay. And they can cause infections, serious infections that can permanently cause vision loss. So there's others, but those are the ones that we want to make sure that the audience knows that we want to see those patients within 24 to 48 hours.
Okay, all right.
A quick note on contact lenses before we skip that one.
Yeah.
So 2 things that are very important is you never sleep in your contacts and you never swim in your contacts. That increases your risk tremendously of catching an infection that can be serious.
Okay.
So those 2 things are big no-nos with contact lenses.
Even if you have the little goggles to swim?
You can, but I prefer not to.
Okay.
Yeah, it's safer not to.
Okay, so talk to me. We've talked about stuff that's urgent, but what are common eye problems that are urgent but not an emergency?
That's an excellent question. So I like to define urgent eye conditions are conditions that cause swelling in the eye, redness, a little bit of a discomfort. These are conditions that can be treated, don't have to be seen within 24 to 48 hours, but preferably within a week or so. They should seek medical attention. Some of the common ones we see in clinic every single day is 1, significant allergies to the eyes, Pinkeye, which is a viral infection of the eye that can be contagious. Inflamed pterygiums or carne sudat is very common here in El Paso given the sun and the exposure to the sun. Those are some of the things that we see very common.
Okay.
And I forgot lid infections. Those are very common too. So styes, chalazions, any swelling in the lid, those are things that we usually like to see within a week.
Okay, so it's a good idea to make an appointment and go in for those.
Yes, absolutely.
Just not emergency, not super fast. Talk about what type of emergencies are common with children. What are you seeing children for?
2 major things we see with children that are very common. 1 is chemical injuries, and this usually happens, just like Dr. De La Torre pointed out, at home. So believe it or not, most of the eye injuries actually happen in the household, and we're going to kind of touch base on that.
Okay.
So chemical injuries, that's 1. And 2 is toys. I would like to talk about both of those really quick. So chemical injuries is very important to keep the chemicals out of reach of the children. 2 things in common that we see a lot is 1, the detergent pots. The kids kind of start throwing them on each other, and then we see them kind of hitting the face, kind of burn the skin and the eye. So that's 1. And 2 is super glue. I don't know why, but they tend to kind of stuck their eyelids shut with super glue. So those are 2 things that you really need to have adult supervision all the time. Make sure they're out of reach of the children. For toys, it's very important. There are some toys that I do not allow in my home, and I tell my patients the same. So any projectiles, so bungee cords, nerve guns,
darts,
BBs.
guns.
Yes. Even if they're soft, if they're plastic, the eye is soft also, and with high velocity, they can cause significant damage. The other one is anything with sharp edges. It's very important to kind of yourself pick up the toys and make sure they're age appropriate. Anything that's sharp, they should not be playing with it. And then the third thing that's very common too, they should not run with objects in their hands. So the very common injury is actually a pencil. So kids run with a pencil, they trip, and the pencil just kind of hit their eye. So that's something that they need to be careful of.
Okay. If someone has an eye emergency, should they go to an emergency room?
Yes, but before that, I want to talk about the common emergencies in adults, because the population, the emergencies kind of like change with adults. And in the adult population, we see a lot of these traumas related to falls. Older people, they fall and they hit their eyes and their face. Motorcycle and motor vehicle accidents, and there's direct blunt trauma to the eye. Accidents at work, and these are very common, unfortunately, where there's going to be work-related injuries that can compromise the vision, and sport-related injuries as well when you're playing basketball, volleyball, and there's injuries to the eye. All those, when they happen, we're always concerned about potentially injury to the globe, ruptured globe, or bleeding inside the eye that can compromise the vision, cause pain, cause loss of vision. So with regards to other emergencies in adults, anything that there's acute loss of vision, we consider an emergency. And in the case of adults, we describe them and separate them between painful and non-painful. And where there's painful loss of vision, the most common are going to be foreign bodies to the eye. So the metal grinders, the ones that are banging metal to metal, there's going to be pieces of metal that are going to be coming and flying to the eye. And there'll be decreased vision, and there'll be pain related to that. Contact lenses, we talked about them, how they can get people in trouble, loss of vision and pain associated, as well as acute glaucoma. And these are patients that have sudden onset of no trauma related, but there's pain and nausea and vomiting and a headache around the eye. And then the ones that are loss of vision but non-painful, that's your retinal detachment. And retinal detachment, it's one of the things that you want to get right away into a specialist, because the retina, it's nerve tissue, not like our nails or our hair that grows back if it dies. The retina, if it loses blood supply and we don't get it reestablished right away, there can be permanent damage. And also strokes, and nerve strokes, retinal strokes. It can happen with high blood pressure, can happen with diabetes, and we want to attend those. And those are going to be causes of loss of vision without significant pain or no pain.
Okay.
So those are going to be, now, when those happen, if it's a kid or an adult, we want to get right away. So Dr. Solomon will talk about that.
Okay.
For kids?
Yes.
So it's very important. Again, adult supervision at all times, making sure they're playing with the appropriate toys. Anything that's projectile or sharp should be out of reach. They should not be doing that. Prevention is a key. The eye is a very sensitive structure, so I always emphasize prevention. But what happens if we actually have a trauma to the eye? So if it's a chemical splash to the eye, the first thing you want to do is kind of rinse the eye thoroughly with tap water. There is a specific eye wash that you can get from the pharmacy, and I would use that whole bottle and kind of rinse the eye as much as you can until you go to the emergency room, or preferably to the eye doctor.
And that eye wash would probably be a good thing to have in a first aid kit at home.
Absolutely.
Okay.
You should have it at home. And I want to point out, it's better to go to the eye clinic if you can. So if it's our clinic is open throughout the week and even on Saturdays. We have booked slots for emergencies and walk-ins, so you would come in right away, because oftentimes at the emergency rooms they don't have enough equipment or the specialist on call. So you can always call us or kind of just walk in. That would be better. But if it's after hours or it's like a Sunday, I would go to the emergency room, and UMC, University Medical Center, have an ophthalmologist on call. So that would be my go-to if it's a significant eye injury.
Okay. Dr. De La Torre, talk to us about preventing eye trauma. How can we go about doing that and keeping ourselves in good shape?
So the main thing is prevention, and being proactive about identifying those activities that are going to be potentially at risk of trauma, and then wearing eye goggles. We can do sunglasses, safety glasses. So when we're working in the yard here in El Paso with our dust and windy days, we want to be using eye protection. It's very important also to be inspecting for potentially hazards in the house. So if we have a patient that is elderly and they have difficulty walking, that we want to survey the house, make sure that there's going to be no sharp edges that potentially can be injuring the eye. Also, with regards to also the toys, we want to make sure that those toys that are projectile or have sharp objects, that we keep them. And if the kids are going to be using them, we prefer not to, but if they're going to be using them, there's Nerf guns that they have eye protection. If there's BB guns, that they have eye protection when they're using them. Gotcha is another one that you want to go. It's okay to play gotcha, but there's going to be eye protection involved with that. And the chemicals, any chemical that potentially can splash to the eye. If we are working and we're cleaning our front yard, or we're using sprays that are going to be splashing, we want to be using eye protection. So it's all about prevention.
Okay, keep yourself safe. We do have a couple of questions. And I actually think one of these is great to do right now. A patient suddenly lost their vision, and this is 24 years after a traumatic brain injury. How often should someone who has had an injury of that scale see a doctor to maybe prevent something like this from happening?
So that's a great question. So if you have a significant brain injury, you need to get a baseline eye exam, and based on what the findings are, that's going to dictate what the follow-up frequency is going to be.
Okay.
Sometimes there's significant damage to the optic nerve, sometimes there can be a retinal detachment associated with it. So depending on what pathology there is, that's going to dictate how frequent they need to see the eye doctor.
Okay.
With regards to brain trauma, I had the pleasure of serving in the U.S. Army, and I treated a lot of soldiers that had traumatic brain injury. And this is something that it's now becoming more common, and we're more conscious, especially with football and concussions that are related to sports. Any type of vision loss that is related with a closed head injury. So therefore, there's no blood involved, but there is definitely a loss of consciousness. And if there's any vision changes, you want to be coming right away. But in my experience, one of the most underestimated symptoms related to a closed head injury, a traumatic brain injury, is light sensitivity. And it's been proven that light sensitivity, it's one of the manifestations of a concussion or a traumatic brain injury. And we had a lot of soldiers that they had an ID blast and they had a closed head injury, and the way that it manifested was not blurry vision, was not double vision, was severe light sensitivity. And so there is many ways that this can manifest, and so if there's any change in the vision, even though there was no direct trauma to the eye, you want to have a baseline eye exam like Dr. Solomon said, and then depending on the findings, then the schedule will be determined after that.
Okay, all right. Stay on top of that. And the second question, the person's asking if you can provide an answer in Spanish. A diabetic patient has suffered from a retinal detachment. Are there eye drops that can help, is what they're specifically asking.
So I'm going to go to the Spanish default if you don't mind. So,
please.
Este paciente tiene diabetes y tuvo un desprendimiento de retina. El desprendimiento de retina, como hablamos, es una condición que lamentablemente si no se atiende a tiempo va a potencialmente causar pérdida de visión permanente, y lamentablemente no hay gotas para tratar ese tipo de condición. So, mi recomendación es si hay desprendimiento de retina, que se vea con un especialista, y si hay una condición que tenga que ver con la retina, gotas lo más seguro no sea la solución. Hay tratamientos, hay láser, hay inyección, hay cirugía dentro del ojo que se puede hacer para tratar la diabetes en el ojo.
Okay, and in a nutshell for me?
So pretty much diabetes can cause retinal detachments, and there are the most difficult retinal detachments to treat. And when there is a retinal detachment related to diabetes, rarely a eye drop will fix the problem. So patients typically come see us, we refer them to a retina specialist, and the retina specialist most of the time will treat this type of condition with surgery, lasers, or medications that are injected into the eye. But eye drops most likely won't do the job.
Okay. Let's kind of resume my little list of things that I was curious about. Is a cataract an eye emergency?
Oh, that's an excellent question. Cataracts are one of the most common conditions we treat in the clinic. There are different types of cataract. The most common type, what is a cataract to start with? Cataract is clouding of the natural lens that we have inside our eye. It happens over time. So if all of us, if we live long enough, it will all have cataract. So that type is the most common type, is just that age-related. There are some other conditions, other cataracts that are related to trauma, related to some people are born with it. It's called congenital cataracts. So in general, cataract is not an emergency.
Okay.
Unless it's related to trauma and it's causing some acute rise in eye pressure, that's the only condition where we need to go in emergently and do surgery to fix that cataract. But the normal cataract that's associated with age in itself is not an emergency, but it can cause emergencies. So reduction of vision, reduction of your depth sensitivity is usually in older people, can lead to falls. You can fracture your hip. Driving is not safe. You can be involved in an emergency. So in that sense, it is. So if the cataract is affecting your vision in a significant way, yes, it needs to be treated.
Okay.
And this is something that we, in the last program that we were here, we discussed, but I want to re-emphasize.
Please.
That like Dr. Solomon said, everybody at some point will develop a cataract. And we hear that term and we get alarmed. We think, oh, they're telling me I'm old, and that's not the case. And one thing that I've learned here in our community is that people tend to confuse cataract with carnosidad because they sound similar. Okay. And carnosidad is what Dr. Soliman treats. It's pterygium. But they sound the same and people get it confused. So I often, when I see a patient with cataract, I ask them, what is a cataract? And they almost 9 out of 10 times they answer, oh, that's the film that grows over the eye. And that's a pterygium. That's not a cataract. Oh. So when you have that redness that you can see in people's eye that is covering the eye, that's a carnosidad. We call that a pterygium. And that's very common in the Southwest because of our sun exposure. It's sun damage to the eye, and it grows as an extra layer of skin that is growing over the eye. Because they sound the same, they confuse them. The cataract is inside the eye. You don't see the cataract. So you cannot see someone's cataract. To see a cataract, you have to dilate the eye. You need a microscope. You need to have a comprehensive eye exam. So in order to remove the cataract, we have to go inside the eye and remove it. Okay. So I want to make that point because a lot of people confuse cataract with carnosidad, and they're not the same.
Until just the second, I thought exactly that. So,
and a follow-up on that, a lot of people still to this day come to me and say, I was told my cataract is not ripe yet. So things changed a lot. In the early days when we were just beginning eye surgeries, maybe in the 70s, people used to wait until they completely lose vision. They can barely just see their hand in front of their face before doing the surgery, because the surgery was a major intervention. It was associated with a lot of complications, but that's not the deal anymore. So now with the technology we have and the lasers and the instrumentation, the microsurgical instrumentation we have in the OR, we do not recommend waiting until it's that significant. We can restore your vision. We can have you see 20/20 and enjoy many, many years with great vision with really minimal complications.
And that's important. It keeps you out and active.
Absolutely.
And it's an important thing.
And cataract surgery is covered by most of the medical insurances. So this is a surgery that is safe, that is effective, and is covered by most medical insurances. And no longer there is a vision requirement. Therefore, you don't have to wait, or we don't have to wait until a certain loss of vision has been achieved. If the patient has loss of vision and they have difficulty performing their activities of daily living, that's an indication for surgery. So no longer Medicare insurances, they are making us wait until the patient has that amount of growth or that vision loss that we consider significant. If the patient is affected daily, we can proceed with cataract surgery.
You, again, get it treated before it affects your quality of life or your mobility or whatever. That's great.
And one thing I would also mention is that the surgery itself takes us about 5-10 minutes. People they laugh when I say that.
Yeah.
And I actually invite family members to come into the OR. I'm not sure if anybody else does that, but we would allow you to come in, watch video if you want the surgery. It takes 5-10 minutes. It's painless. The way we do it with topical anesthesia. So we don't use any needles. We don't put you to sleep. Recovery is right away. You wake up with a clear shield over the eye so the eye is not covered and you can see immediately. So that's something everybody needs to know.
Yeah, and I guess a lot of it comes from just what was done once upon a time, and people don't realize that technology has improved and your capabilities improved, and it gets better and faster. Let's talk about eye trauma at home. Tell me how common is it? You know, how often does stuff like this happen to your average person at home?
It's very common, and it's estimated in the U.S. that about 2 million eye injuries happen at home every year. And this can be chemical injuries, which are when we're performing our cleaning chores, or when we are playing sports at home, work-related injuries as well. These are unfortunately very common, and what we want to address is, what do you do when this happens? And the first thing is that we do not want to rub the eye. If there is an eye injury, you don't want to put external pressure to the eye. If there is an injury to the globe, you could actually make it worse by rubbing the eye or putting external pressure. If there is, for example, a chemical like Dr. Soliman addressed, you want to profusely irrigate, and you want to irrigate for at least until the bottle is complete, because there is remnants of the chemical that stay hidden in the eyelid. So you want to use the full bottle of that eye wash. and it's a good idea to have a bottle of eye wash at home. And if there is an eye injury, you want to go in right away and get help. And if you cannot get to our offices, we have an east-west location. UMC, it's the best way to go.
Okay.
And I would add to that a couple things. One, if there's a foreign body in the eye that you see it, don't remove it. Okay, don't try to remove it. That's one. Do not use over-the-counter medications on your own. If it's a chemical injury, wash it until you come to the hospital or to the eye clinic. If you feel that the eye is cut, there's severe, significant trauma to the eye, again, like Dr. De La Torre said, no pressure on the eye, no rubbing, just leave it alone and come immediately to the eye care professional, and he will take care of it. One thing, I need to stress prevention. One of the common things that can cause eye injuries at the home is gardening. So always wear eye protection, whether you're doing gardening, you're hanging a picture and you're kind of hammering a nail, you're grinding in your garage. Eye protection is key. Do not mix chemicals. That's very important because sometimes a reaction can happen and it can splash back. So that's another thing to keep in mind.
Okay.
And do not use over-the-counter medications experimentally. One that is very common in our community, it's manzanilla, chamomile. We tend to just add chamomile for everything. And unfortunately, I've seen patients that they get to us too late because they've been self-treating themselves with chamomile. And so you don't want to go to the pharmacy and experiment. You want to go in right away if there's been an eye injury.
Okay, we have more questions from call-ins, and so we'll just kind of go through these. Is there an alternative way to examine the eye that is not a bright light? This patient reports that the light causes him pain, and he's worried that the light is damaging his retina or his optic nerve.
That's an excellent question. So the answer is yes, but before I go into that, the light that we use, it does not damage the retina.
Okay.
It's a very brief exam, and it's kind of measured and controlled, so it will not damage your vision. One thing I want to mention, when we're doing the comprehensive eye exam and we dilate your eyes, your vision will be blurry, especially for near activity, for at least 4 to 6 hours afterwards. So driving is not a good idea, so you always want to have somebody come with you that day, and don't have like a lot of homework or assignments or like something big that you need to do when you go back home. That's something to keep in mind. The light does not damage your vision. We have new technologies now with infrared cameras that can image the eyes with minimal light exposure. So there are a lot of things that we can do, but definitely that would not hinder them from coming in and getting their eyes checked.
Okay. How can someone on a budget afford glasses or bifocals?
Well, there is certainly, first, the comprehensive eye exam, which is covered by most of the medical insurances, but we do have many self-pay patients, and we pride ourselves that we do not deny care. So even if there's no insurance, we'll take care of the patients. So the exam will determine the prescription, and then the glasses part, we have no control, so we give the prescriptions to the patient, and then they can go wherever they want for the glasses. One thing that we've developed in our office, and this is to keep a great relationship with our optometrists in town, is that we do not, in our practice, sell glasses or contact lenses. So we do the comprehensive eye exam. We can do the prescription if needed, but we let the patients go get the best price. And if they're in a budget, there's places out there that can give them a very good price on glasses and contacts. But the comprehensive eye exam, it's most likely going to be covered by your medical insurance or your vision plan. And even if you don't have insurance, we have very affordable prices for that exam.
Okay. Can you explain floaters? What can cause permanent floaters?
That's an excellent question. So floaters is basically, if we can pull up the slide for the eye, the cut section of the eye, this would be a good time for it.
Our first slide.
So the back of the eye is filled with a jelly. That jelly is called vitreous. Okay. It's basically made out of collagen. And at some point in your life, as we can tell over here, so the front part of the eye, this is a cut section in the eye. The front part, kind of like the windshield to the eye, is called the cornea. And then we have the colored part, which is the iris, that can be brown or blue. And through it is the pupil. That's the hole through which the light enters to the back of the eye. There's the natural lens there that focuses the image onto the retina, and that's where the cataract happens. Just like Dr. De La Torre mentioned, the cataract is inside the eye. It's behind the iris. You can only evaluate it by a microscope after dilating your pupil. And then behind the lens, there's the cavity of the eye or the cavity of the globe. That's what's filled with the vitreous. And then at the very back, the inner lining is the film in the back of the camera. That's called the retina. So the floaters happen in the vitreous, which is the jelly that's filling the back 2/3, if you would, of the eye. Some of the collagen fibers over the years can start to be cloudy. And when the light hits them, they kind of cast a shadow on the retina. And that's what we see as floaters moving around. It's more pronounced if you're looking at a white background or you're looking at the sky. And having a few of them at some point in your life is common for almost everybody. In itself, it's nothing serious, but when it is alarming and you need to get that checked is if there's like hundreds of them, not just like 2 or 3, blocking your view. If it's associated with flashes of light, you're sitting in a dark setting and there's like a flash of a camera going on, which is from your eye, nowhere else, no external source for it. And more importantly, if there's a shade or a curtain coming down that's blocking your side vision, that's not going away. All those are signs that there might be something serious going on with the retina, whether it's a tear in the retina or a detachment, and that needs immediate attention to make sure it does not cause any permanent vision loss.
Okay. Let's talk about the difference between a macular hole and a retinal detachment with macular sparring.
Okay. So those are very technical.
That's very technical.
But they're good questions. So a macular hole, the macula is the center of the retina, and it's the area that we have designed to help us give us the sharpest vision. So 20/20 is seen with the macula, which is the center of the retina. When there is a macular hole, there's been pulling forces on the macula. Typically, they are coming from the vitreous. As the vitreous starts to get old and degenerates and creates floaters, it starts to pull on the retina. And if it pulls with enough force, it can create a hole in the macula. But this hole does not typically progress into a retinal detachment. The retinal detachment is when these holes, especially they develop in the periphery of the retina and allow water and aqueous to build up below the retina and lift the retina. And that's when, if the retina is elevated and detached, it constitutes an emergency and needs to be seen right away.
Okay. This next one I'm kind of fond of. Every woman on the planet has probably thought it at one time. What causes under eye bags besides being tired?
Well, the globe is inside a bony socket called the orbit, and the orbit has, by design, a fatty tissue around, so the eye is not banging against the bony walls that surround it. And that fatty tissue, with time, starts to move forward. And the under bags, and they can also happen in the upper eyelids in the inner corner, they are fatty tissue of the orbit that starts to come forward as the skin of the eyelid starts to get loose. It allows that pocket to come forward. Good thing to add, these can be treated, but unfortunately not with eye drops. And there is a lot of treatments. Icing them in the morning helps to some degree, but they tend to be related to water content. So patients have edema, legs get swollen, they tend to have more bags. And also, in my experience, they also are related to how you sleep. If you're a side sleeper, you will wake up and there will be one bag bigger than the other. So it's depending on the position. There is surgery for it, and we do have specialists in our office that can treat them, but this is something that most likely will require surgery. There will be no eye drops or creams to get rid of them.
Okay, but it is treatable.
It is treatable.
Okay. Let's talk a little bit about cataract surgery. Again, thank you everyone who's called or gone on Facebook for the questions. This one is just explaining, and I have never seen this word before, a capsulotomy?
Uh-huh.
Okay.
Oh, these are really technical questions. So the lens inside the eye, if you think of it, I explain it to my patients, it's like an M&M. You have a chocolate shell, and then you have the chocolate inside. That chocolate shell is called the capsule. That's what's holding the lens. And then the lens material is inside. That's the chocolate. So what we do in cataract surgery, basically, we want to gain access to that cloudy lens material and get it out of the way. So we do a capsulotomy. we do a perfectly round circular opening in the front part of the chocolate shell, if you would. And then we suck the chocolate. We have different ways of doing that, whether it's with phacoemulsification, that's using ultrasound energy to emulsify it and suck it out of the eye, or even laser-assisted surgery, which helps us do that as well. After we remove the cataract, we are left with the chocolate shell with that hole, and we use this shell to house the new lens that goes inside that shell and stays there perfectly centered on the pupil, and it can focus the light again exactly on the retina, and you can see 20/20 again.
Oh.
Okay, so that's a capsulotomy. And then we can talk a little bit, if we have time, about the different lens options too. So we have a lot of different options when it comes to which lens we use, and this is something that is individualized. We do a lot of measurements to your eye, and based on what your eye looks like and what it needs, we correct it to get you the best vision possible, whether it's for distance, for up close, for intermediate activities. So there are a lot of options there too.
Okay.
And I want to add that maybe the caller is asking about a surgery that is done after cataract surgery that is called capsulotomy, and this is where that capsule over time can get cloudy. And the lens itself that is inside, this artificial lens that we place at the time of cataract surgery, we don't have to replace it. So that the person gets that lens and stays with it for the rest of their life.
That's still fine.
Correct. But the capsule itself can get cloudy, and this can happen months later or years later. And there is a laser surgery, also covered by the insurance, that will clean, if you will, the lens and will open the capsule behind the lens to allow the light to go through the lens without being affected by that scar that forms behind the lens. So the capsulotomy is done during the surgery to open the capsule, and it can be done after the cataract surgery if the capsule gets cloudy, to allow the lens to do its job and not have a scar get in the middle.
Okay. Okay. It sounds like good progress and lots of good options. Do either of you have any thoughts about the glasses that you see them advertised on TV from time to time that are blue light filter glasses?
Yeah, so
what do you think?
Well, this is coming based of all this new ways of getting information via iPhones, iPads, Android devices that are emitting blue light to our eyes. And it has been proven that blue light can cause more oxidative stress to the retina and can cause macular degeneration. In some cases, argued that could increase the risk of cataracts. This is something that with occasional use we're not going to be alarmed, but it has been introduced to use these blue light blocking glasses, and I think there is a role to it, but personally, in my experience, I don't think that just doing that is going to really make a big impact. With regards to macular degeneration, which is the most concerning, sun protection, it's important. Avoiding smoking is extremely important. And if there's family history of macular degeneration, you want to go in to have a comprehensive eye exam because you're going to be at high risk. And if these are all together, then the higher the risk. So if you have family history and you are a smoker and you spend a lot of time on these devices or in the sun, that oxidative stress from smoking plus the use of the devices and your family history, the genetics, you're going to be at high risk of macular degeneration. So, but one thing only won't be enough to increase the risk.
Okay. This patient had trauma in childhood resulting in loss of some vision in his left eye. His optic nerve was preserved, and he's wondering if there are any new procedures or technologies that might be available to improve his vision.
That's a great question. So it really depends on what his age was when that trauma happened, because there's a critical age, usually up to, some people say up to 7 years, some people say up to 9 years. If you had significant vision loss or a significant trauma to your eye in childhood, that can cause what we call a lazy eye or amblyopia, where the brain starts to lose interest in that input coming from that eye and prefers the other eye that sees very well. So the nerve might be preserved, but if it happened during that critical window and the brain lost interest in that eye, or he developed a lazy eye and now he's in his 30s or 40s, it's a little bit difficult. to kind of correct that. But if he's still younger, there is a lot of new technology. So if he's still like it happened, he's like 2 or 3 years old and he's 9 now, there are new technologies that can help and new treatments for lazy eyes that can help actually restore the vision. So it really depends on the specifics of his condition.
And this is a very common scenario that I see in the clinic. And my recommendation for these type of patients is to come in and have an eye exam. That if in the past you've got an answer that you didn't like, give us a chance to re-examine the eye and maybe we have an alternative. But one thing that I explain to these patients that is often the case is that, like Dr. Solomon said, we cannot reestablish 20/20 in these patients, but we can get some functional vision. And I use the example of having a car with a spare tire, but the spare tire, it's flat. So that spare tire is not going to help you. So if you have a lazy eye, but that lazy eye is essentially blind and has a visual potential, let's try to achieve the best visual potential to that eye. Even though it's not going to be lazy, we want to have that eye ready in case it has to jump in and help out. God forbid you get into an accident, you have a contact lens related injury, a foreign body on your good eye, your lazy eye is there to help you rather than not seeing at all. So if you have a flat tire, you have that spare tire, jump in right away. But if your spare tire is also flat, it's there and for nothing.
Take care of what you've got. Okay, if a patient's eye has been twitching for 3 or 4 weeks, should they see an ophthalmologist?
I love eye twitching because it is one of the most common
and
things
annoying
that we get. And so one thing that I've noticed is, especially with all these devices that we use, are to some degree love for coffee. It creates a perfect storm. And the patient that the eyes twitches is usually the same scenario. It's a patient that is not sleeping well, that because it's not sleeping well, wakes up tired and wants to stay awake using coffee, which is an stimulant, or Coke, or any caffeine product, Red Bulls, the Monsters. And then they are on the computer, they are on the devices, and their eyes are getting dry. And that's the perfect storm that is growing that will create the twitching. So eyelid twitching, it is an irritation to the ocular surface and a nerve that is irritated and starts to trigger on its own. Involuntarily, it starts to twitch. And it can be the upper lid, the lower lid. And some patients, they are the only ones to feel it. Sometimes it's even obvious that it's twitching. So that patient comes in, and most of the time, the day that they show up, the eyelid's not twitching. And they're very frustrated. But we believe them because we know it's usually the same story.
And they got a good night's sleep before they came to see you.
Exactly. So, but everything starts with having a good night's sleep, try to limit the caffeine uptake, and keeping the eyes lubricated. And most of the patients, that will take care of the twitching. But there are patients that the eyelid twitch all the time. And that's a condition. That's called blepharospasm. And those patients that are twitching all the time, they can benefit from Botox. Not for the cosmetic approach, but for the functional approach. And this is covered by the insurance. So if you're a patient that your eyelid twitches all the time, then please come in for an eye exam because we could get Botox covered and help you with that twitching. It typically takes an injection every 3 to 6 months, but it's very effective in getting rid of the twitching.
Okay. And we have a lot of questions about macular degeneration. Someone wants to know if supplements can help with or prevent age-related macular degeneration.
That's an excellent question. So macular degeneration, one of the common things that I see a lot in the clinic, there are 2 major types of macular degeneration. So to start with, macular degeneration, the macula is the central portion of the retina. The retina is the film in the back of the camera. So degeneration means it's the central part of the retina is losing its function over time. That's basically what macular degeneration is. The most common form of it is age-related macular degeneration. It happens over time. It usually has a genetic predisposition to it, so it runs in families, but you can be the first one in your family to develop it. So if you don't have a family history, that doesn't mean you're safe from getting macular degeneration. And again, early on, has no symptoms, so I'll go back to the comprehensive eye exam. That's why we want to pick up these changes that are silent, they're asymptomatic early on, because the earlier that we pick them up, the better the prognosis is. We have dry macular degeneration, and then we have wet macular degeneration. So there are two big forms of them.
Okay.
Dry macular degeneration means the cells of the retinal pigment epithelium, the cells of the retina are losing their function, but there's no bleeding, there's no swelling, there's no fluid underneath the retina. That's what the wet portion is. The eye supplements, there are huge studies that have been done on a national scale that have proved that particular formulations of eye vitamins can help slow the progression of the dry type of macular degeneration and prevent the formation of atrophy or scar tissues in the retina. So yes, it does help in slowing the progression of the macular degeneration, not preventing it. Okay. But if you do have the wet type of macular degeneration, we now have a lot of options of medicines that we use actually to kind of reverse that swelling or that bleeding and kind of get your vision better. So that's why it's key to see an eye doctor or a retina specialist to determine which type you have and what treatment is right for you.
Okay.
And our colleague, Dr. Elman, who's the founder of the Southwest Eye Institute, he formulated his own brand of eye vitamins and supplements, and these are after a study that's called the ARIS studies, age-related eye disease study, and the second version of the study proved that there's a combination of eye vitamins that can help prevent the progression of the macular degeneration from the dry form to the wet form. And we do have those vitamins available in our office. There's also a website, luxbite.com, that they can go, and also there are in Amazon. But we do have eye vitamins that can help the progression of macular degeneration.
Okay. And this is kind of, I think you sort of answered this. Can prescription, and I think it's ARED, it's a pill, a chew, help patients with macular degeneration? Correct,
and that's the vitamins that we're referring to, and those are antioxidants preventing the oxidative stress of the retina.
Okay. Now, if you suspect that you have macular degeneration, or if you go to your optometrist or an ophthalmologist and they tell you that, is that an eye emergency?
Oh, that's an excellent question. So in itself, it's not an emergency, but you need to get further evaluation to determine, is it of the dry type, is it of the wet type, do you need injections of medication inside your eye or not? So I would get an evaluation by an ophthalmologist, but not as an emergency, but within a week or two.
Okay. Okay. And let's, we haven't talked about kids a lot in eyes. We talked related to emergencies, but an infant, for instance, how can a parent tell if an infant is blind or has trouble even seeing?
Well, visual behavior and in the early stages, kids, they don't develop, infants in this case, they don't develop 20/20 until they're 2 years old. And in an infant, less than a year old, we go about eye behavior. So they should be, when they're feeding, they should be looking at their parents, they should be making eye contact, they should fix and follow their vision in a target. One thing that if you are concerned about if the kid can see or not, you can always bring them in, but one test that I was taught that is very easy is to have, for example, the sprinkles that you do for ice cream.
Okay.
And show the kid the sprinkle. They should be able to select one. And if your kid cannot go for that little sprinkle, most likely they are not seeing well. So that's a simple test that can be done at home. But it's about eye behavior. It should be about fixing and following, tracking. The pupil reaction is another way that we determine the pupil should be able to react. That's how we determine in kids that they're nonverbal. They cannot tell us which is better, one or two.
Yeah, that's hard. And what age do you start eye exams with children?
So the eye exam for children, there's a lot of controversy. Unfortunately, we haven't got into a decision in terms of nationwide recommendation, because for example, hearing screening, which is done right away as we are born, and is also part of screening for school, For eye exam, unfortunately, there's no consensus because there's some controversy of who's going to perform this screening. Is it going to be an ophthalmologist? Is it going to be an optometrist? And so we recommend the parents to observe their children, observe the visual behavior, and most of the cases of when the patients come in, it's either because their parent have noticed that visual behavior or the teachers have noticed that the student struggles or they squint when they're in school, and that's how we get the patients. But recommended age, unfortunately, we don't have one.
Okay.
I would add to that two things.
Please.
One, if you ever notice that the eye is crossing or wandering, that's a sign that you definitely need to get your eyes checked.
Okay.
Two, I tell my patients that at least before the age of 5, get an eye exam just to make sure they don't need glasses. A lot of times if they do need glasses and they're kind of going by and nobody's noticing it, if they continue like that, they can develop some form of a lazy eye. So it's a good idea to just get a one and done exam from 3 to 5 years of age, up to 2nd grade maybe in school, just to make sure we're not missing anything, even if they're not concerned. Obviously, if they're concerned, they need to come in sooner.
Okay. All right. We've got a couple more calling questions. Reverting to, let's talk about cataract surgery again. Are intraocular lenses better, or can a patient use contacts and glasses? I guess that's after the surgery.
In the old days, what they used to do is they used to remove the cataract, which is the cloudy lens, and leave the patient aphakic. Aphakic means no lens inside, and then he would have to use either really thick glasses or contact lenses. That's not the case anymore. With the technology we have right now, we remove the cataract and we replace that lens, the cloudy lens, with a new clear lens in the inside of the eye almost on every patient. There are a lot of different types of lenses, but yes, we do, and that we do put a lens at the time of surgery, and that is better than just using contacts or glasses.
Okay.
And there is new lenses that can correct the refractive errors of the eye, meaning nearsightedness, farsightedness, astigmatism, and presbyopia. And the traditional lenses that went inside the eye used to be that they were what's called monofocal, or they only have one prescription. And those patients typically get the monofocal and they still need glasses after. Now we can accurately measure the eye, and the lens we can choose to carry the prescription of the patient. Essentially, you get rid of the cataract, but also you have a high chance of getting rid of the glasses as well by customizing the power of the lens that goes inside the eye. And this is something that we're trying to educate more the patients, and we think that as we're facing to a new generation, the baby boomers that are coming to get cataract surgery, that they're more knowledgeable about what are the options towards cataract surgery. Some of these options are unfortunately not covered by the insurance.
Yeah.
And they think that because we're offering them and they're not covered by the insurance, that they're better than the regular lenses, or that we're trying to sell them a product. And that's not the case. We want every patient to have the chance to choose what's the best lens for them. And there are patients that would benefit from this latest technology, and there are patients that will do great with the monofocal lens and wearing glasses as they've always had. So we want to customize the surgery, and that's why when you go to have a formal eye exam and potentially a cataract evaluation, don't be surprised that they talk to you about these new options that we have that are available and that we should take advantage of.
I have a friend, in fact, who had it done recently and doesn't have to wear glasses anymore and is thrilled.
Yeah, absolutely.
And because she's like me, she had always worn glasses, and now that that's not an issue, she's been really, really happy with it. We're getting to the end of our program. We still do have one more listener question, one more viewer question. Does high cholesterol correlate with high ocular pressure?
No.
No.
So, but it can cause problems in the retina. So you really need to get your lipid and your cholesterol under control, because it can cause swelling or what we call hard exudates in the retina that can compromise your vision, or macular edema it's called. So your blood pressure, your blood sugar, your lipids and cholesterol all can affect your vision.
Talking about the high eye pressure is associated with a condition that we didn't talk too much about, but we can touch briefly. It's called glaucoma. And glaucoma, it's when there's high eye pressure, enough build inside the eye that can damage the optic nerve. And the optic nerve is like the USB cable of our camera that downloads the picture of the eye to the brain. And the high eye pressure can develop acutely, or it can take time to develop, but you want to have an eye exam. If you have a family member that has glaucoma, that puts you at high risk. African Americans, Hispanics were at high risk of glaucoma, so those risk factors are taken into account. And if there is, or you've been told that you have high eye pressure, you want to have a comprehensive eye exam, make sure you don't have glaucoma.
Okay, and so if you go to, for instance, your optometrist and they tell you, I think you have glaucoma, should you schedule an appointment with an ophthalmologist immediately?
The optometrist can do the exam to determine if there is glaucoma or not. But in Texas, if they determine that there is glaucoma, then they do require to have an ophthalmologist confirm the diagnosis and determine what's going to be the treatment plan, and then the patient can continue the treatment with the optometrist. But yes, to answer the question, if there is the mention that there is a risk of glaucoma, you want to have a comprehensive eye exam, either with an optometrist or an ophthalmologist.
So that falls under the emergency category.
Urgency.
Okay.
More than emergency.
Okay.
Yeah.
All right.
A couple of things I want to touch base on.
Okay, we have about a minute and a half.
Oh, okay. One thing is related to cataract surgery. There's something called dropless cataract surgery, and that's what we do at the Southwest Eye Institute. So I'm not sure if everybody's familiar with that, but you used to use a lot of prescription drops after the surgery for a month. The schedule can be confusing. What we do is at the end of the surgery, we place that medicine inside the eye, so you really don't need any prescription drops after the surgery. And that's something I think is of a huge benefit to our patients, and they're enjoying it. And I want to make sure everybody is aware of that. That's one. Two is diabetes. Diabetes is very common here in El Paso, and there's a condition called diabetic retinopathy, where the diabetes can affect the retina in the back of your eye, and for the most part, it has no symptoms early on, and the only way to pick it up is to get your comprehensive eye exam. Again, back to the importance of getting your eyes checked. So if you do have diabetes, you need to get your eyes checked at least once a year to make sure you do not have diabetic retinopathy.
Okay. I want to thank our doctors this evening, Dr. Javier De La Torre and Dr. Ahmed Solomon, both from the Southwest Eye Institute. Thank you very much for being here and answering all of our good viewer questions. We also want to thank Aaron Pines, who is one of our medical students who has been here taking calls. And thank you very much, Aaron. You did a great job. We appreciate it. This is the El Paso physician. I am Flo Toll. I've been in for Catherine Berg this week, and we appreciate you viewing.